All right. Good evening, good morning, good afternoon, wherever you are. Hi, everyone. Welcome to Indian Occupational Therapist Talk with an Expert Neuro OT Practice in India event. As we all know, October 27 was the World OT Day. So, to celebrate that this year, IOTT has planned a series of events. So we had a webinar delivered by Dr. Suresh Kumar Kamalakanan, and then we had a panel discussion last week. And in continuation, we have this expert talk in Neuro today. We also planning to launch our workforce survey soon. So look for an email update from IOTTT soon. I want to take this opportunity to also communicate that IOTTT membership is now open to anyone who's interested. Please go to our website, iott.org, and then look at the eligibility criteria. And I welcome all of you to join IOTTT to empower the field of occupational therapy in India. So we have a great expert here who has been in neuro practice for several years, and more than almost 2 decades of experience in the field of occupational therapy as well. So the rationale behind we organizing this is, as we all know, based on the 2018 workforce study that we have, 72% of our occupational therapists in the area of pediatrics, but there is a huge need in other areas of practice as well. So to kind of to give practitioners the idea of by inviting a successful practitioner from other specialty areas of practice who are practicing in India, so that it's very specific to the Indian context. So by hearing from them, we can find the opportunities. We can also look into other practice areas whereby we can expand our service and the reach of occupational therapy to a wider population, and to the to those patients who might very well get benefited from the OT services. So that's the rationale. We just want to show the students, emerging practitioners, to the potential of all other practice areas. Plus, also, on that note, we will be able to expand the reach of occupational therapy to a lot more people in India. So that's the rationale. And we have a great speaker today with us, an expert who is Dr. Ganapathy. I'm going to, turn the moderation of this event to Dr. Murali Krishnan, IOTT's treasurer, so that he can guide us through and also introduce the speaker briefly. And we all would like to know more about your accomplishments and your career trajectory. Ganapathy, please share it, and then the beginning of the conversation as well. Over to you, Dr. Murali Krishnan.
Hi, everyone. Thank you, Karthik, and thank you, Ganapathy, for joining and accepting the invite.
Thank you so much.
Neuro rehab for us in occupational therapy has a topic which is eluding our clinical practice for a long time, particularly in South Indian context. At least somewhere in some parts of the other country, some other parts of the country, we have people practicing it. Maybe not in the private practice, but at least in the major hospitals and in the government sector. Lot of times, what happens is we end up doing one kind of practice. At the same time, we also see some of the people are doing exceptionally great in that neuro rehab field. So one of that kind of a person is Dr. Ganapathy. I'm really proud of having him here with me for the discussion. We studied in the same college. We are part of the same alumni from Savita College of Occupational Therapy in Chennai. And he's a good friend of mine, and of course, for Ganapathy and Suresh as well. So this is to introduce him. Since the time I knew him, he went into pediatrics, yes, but then he pivoted back to hospital-based rehab and then neuro rehab. And I knew him from the beginning of PRS Neurocare's neuro department starting. Discussed a lot with him, and his influence has, his efforts has shown through Dr. Sharan, who's the neurosurgeon there in PRS Neurocare. We discuss a lot on neuro rehab. connected through the Indian Federation of Neuro Rehab aspects. So instead of me going roughly over him, I would like to request Ganpati, please introduce yourself briefly so that people will know about you and your expertise in the field, how long you are in the field of neuro rehabilitation.
Thank you, Murli sir. Thank you, Karthik. So let me start with my post here in PRS Neurosciences. In PRS Neurosciences, I'm the head of the Occupational Therapy Department, and I'm also taking care of academics and training. Academic is anybody who is coming from outside, like the physiotherapists, occupational therapy interns, and students who are coming, or any external training which we are doing. And the training vertical is the internal training. We have a learning management system for our staffs, and the internal hands-on training which I'm handling. And I'm also, apart from the occupational therapy, I'm holding another post called Advanced Neuro Rehab Specialist, which is basically you have to have an overall understanding about all the field and also from the clinical side, the clinical neuro and the medications and the patient conditions and the physiotherapy, occupational therapy, the multidisciplinary team. So that you can coordinate that. We have 5 such people who are qualified to become a advanced neuro rehab specialist. Let me explain that why I'm telling all these things. And let me also tell briefly what is PRS Neurosciences. Initially, it was known as Neuro, N-E-W-R-O, Neuro Rehab Center. It's been about 13 years, which is very, very unique center. I recommend all of you should visit and see what kind of quality of work which we are doing. And I will also briefly tell that what kind of work currently we are working on. In our own zone we are working on, it is not explicitly published so far, but quite a huge amount of work is done. It is started by Dr. Sharan Srinivasan, who is a well-known functional neurosurgeon, who is known as a guitar surgeon in Bangalore. He has performed a guitarist dystonia. You might have heard about thalamotomy, pallidotomy, all these kind of surgeries. Usually you hear in Parkinson disease. So he handle all the movement disorders, and he do something called lesioning surgeries. And you can see the dramatic changes which is happening on the table. And also, he's very, very passionate about neuro rehabilitation. I have never seen many doctors who are passionate as much as Dr. Sharan Srinivasan. And his wife, Dr. Pratibha Sharan, who is a doctor and a psychologist, who is the director of the neuro rehab services. And we have currently 100 therapists working with us. We have 5 centers within Bangalore, and we have inpatient and outpatient. I'll tell you in detail about the company and what kind of work which we are doing later. So to start the talk, let me start with my childhood, because you have lots of young therapists who are here. As a child, I was not very confident. I have studied in Tamil medium. I'm coming from a corner in the not corner in the southern corner of Tamil Nadu called Kanyakumari district. I studied in Tamil medium till 12th standard. I had my own struggle, getting into the college, and you have to translate, like from Tamil medium, you have to translate everything into English. And then, these kind of struggles were there, but I could manage well. So initially, when I have taken occupational therapy, I have no clue what is occupational therapy. Not this era. That was 2020, 21, right? So that time, nobody knows what is occupational therapy. Many people do not know what is occupational therapy. So somebody has suggested, we have taken it like that. Even after joining in the college, and we have to take a long time to understand, because the technology was not so much. We to get a 600 rupees book, we have to wait for a long time. All black and white books, expensive books. You don't have YouTube at the time, so it's very difficult to understand what is occupational therapy the way current generation is understanding. So it's a very vague understanding. It take a long time, to understand what actually an occupational therapist does. So that time we used to go to stand in front of the university and promote occupational therapy. So give pamphlet, all these kind of work which we have done. One group of people say that no, why are you doing that? Because the demand has to be there. If so many people come, the profession get saturated. This is one group of argument. The other group says, no, you have to promote this profession. You have to promote the college, because after some time, if you have to tell, I have studied in a college, there was a college called Savita College, rather than you say there is a college, Savita College, I studied. Like currently, we have reopened this Savita College and many other colleges. That shows the growth of the profession. In the last 5 years, it's very obvious so many colleges have started. So I had my own struggle and cope up with that since I was came from the Tamil medium. I have to literally translate everything sentence by sentence. I have to pay extra focus and use dictionary. This is like the long journey. And it took 2 years for me to get well versed with the English. And then the learning was a little smoother. Completed the course maybe about 5 years we have completed. Then I joined in a pediatric center because I came to posting in Bangalore. These are the two centers which inspired me to join in neuro rehabilitation. One is St. John's Medical College. I recommend everybody. It has a very beautiful PMR center, and Limans, which has a very good PMR center. And got an opportunity to get a good exposure that I just wanted to join in Limans or St. John's. So I stayed back in Bangalore. 1 year I worked with the pediatric center, which is called Center for Child Development. And then I moved to St. John's for about 7 years. So St. John's gave me a very unique exposure to PMR. I worked with the PMR, Dr. Kurian Sakaria. It's a very good PMR doctor. And I worked with pediatric. I have an exposure to neonatal ICU. I handle infants as well as adults. So this is a unique opportunity I got, which has given me a perspective of how these two profession are two way of looking at a human life. Occupational therapists handle end to end, starting from the infants to the geriatric. So it gave me a different way of looking at occupational therapy. So in St. John's, it is actually the exposure to neuro rehab, in the sense neuro as an acute care, uh, neurology and neurosurgery is no reference based. But when the patient get admitted in PMR department, it will be about 3 months later we see the patient. That means all the acute care treatments are done. It is no reference basis. But once they are coming into PMR, inside it will be taking 3 months. That means we have missed a lots of acute symptoms in in the process. Unless until you see this end to end, you will not get an idea. So you can consider that I worked as a subacute to tertiary rehabilitation in PMR in St. John's. There we used to handle, like as usual, the head injury, stroke, spinal cord injury, these kind of cases, functional rehabilitation as usual. Now, after that, but this 7 years has given me a good amount of experience, and my salary was very less. And I can tell openly that it was 14,000 in 2014. Take home salary was about 12,000 rupees. And I have to handle my family with my wife and two kids. I have to handle in Bangalore. It was very tough, actually. But what it gave me was later when I completed St. John's experience in neuro rehabilitation, when I joined in Columbia, which was a corporate hospital. This has turned my life upside down. I joined as a consultant, and in 2 months, roughly about 3 months, my take-home salary become 10 times of St. John's. That is almost close to a lakh, which is the learning which I got from St. John's, how to handle neurologically injured patients hands-on from the rehabilitation perspective. Okay, from the how to rehabilitate a patient. So there I worked as a occupational therapy consultant for about 4 years. And then I have gone for higher studies for about 2 years in pediatric. I have done my master's in pediatrics. After completing pediatrics, I have got an opportunity to join in PRS Neuroscience. In PRS Neuroscience, we, which is a very, very unique center. Why? Because it is started by a neurosurgeon. I have an opportunity to see the patient from the day one of neurosurgery or stroke, whatever the condition which has happened, and then I can see the patient till the tertiary rehabilitation. So whenever the patient come into PRS neurosciences, we have a system which we have formulated that we have divided all the neurological patient into two group of people. One is the brain injury, the other group is spinal cord and the peripheral injury. So we call it BIR, brain injury rehabilitation and spinal cord injury rehabilitation. So brain injury rehabilitation, we have something called coma to community. This word which most of the people uses in the rehab field. But what Dr. Sharan and his team, we have formulated is, we have formulated an objective scale, which is called SAFA, Self-Evaluation of Functional Ability, which is a 10 leveled scale, which will give you what is the level of the patient in the journey of coma to community. Because if I tell that I have a son, you cannot predict what is his capability. If I tell I have a son who is going to eighth standard, then you know very well what is his capability. So you will ask the questions based on that. You will test him properly and you will train him properly. Otherwise, you may give seventh standard syllabus or ninth standard syllabus. You cannot really understand what is his capability. So we have come up with a concept called Homa to Community BAR leveling system. We have 1A, 1B, 1C, 2A, 2B, 2C, 3A, 3B, 3C, 4. So 4 is absolutely normal like you and me. So all the patients are segregated as segments, segment 1, segment 2, segment 3. So first segment, second segment, and third segment. So this is done by the patient itself or patient's family members or the front desk, any people who are, before coming into the system itself, they will be evaluating this. Once they evaluate that, they know that where the patient has to go to inpatient rehabilitation or outpatient rehabilitation or a residential rehabilitation or home-based rehabilitation. Anything you can take a decision based on that. Same thing for the cord to community for spinal cord injury patients. Same logic, but cord to community is a different question because spine rehabilitation is and brain rehabilitation is entirely different. Now, once this is done, the next question patient asks is how long it will take for my son or my father to get recover, and how much money I have to spend. Will he recover completely? Now, if you ask this question to a therapist, they answer differently. A doctor asks differently. Sometimes the aide also will tell, sir, 4 years you wait, sir, he will be 4 months you wait, sir, he will become all right. So these kind of statement misdirect the patient. So we want to objectify that also. Now, to objectify that, we have come up with a concept called rehabability index. That what is the rehabability potential? If, first of all, we want to know if the patient is rehabable. The second, how much is rehabable? So to understand that, we have to give input of two things. One is the ICTS to rehabilitation duration when they are coming to us in our system when they are coming. And the second thing is what is his intake C2C score. Based on that, we are giving a output probability of how much the patient can move in the C2C score and how many sessions he require, what kind of rehab setups he require. All these things will be predicted in this. Now you can ask that with this parameter, can you predict very clearly? No, we cannot predict very clearly. That is why we have come up with a clinical framework called CAREPA. CAREPA is CARPA and RAY is rehabilitation. We call in PRS neuroscience is CAREPA RAY framework. So all our ANRS, advanced neuro rehab specialists, are trained in CAREPA RAY framework. So what is CAREPA RAY? When you are looking at a patient, first thing you are looking at a clinical feature. So what is a clinical feature? is, like, for example, like if you ask most of the time when you ask, like, what is the diagnosis? Hemiplegia is the diagnosis. So now we have to change the word when we are coming to neurological rehabilitation. We have to change the language also when we are talking to. So if you ask me what is the diagnosis, what are the clinical features of this patient, the clinical C is the patient has a contralateral hemiplegia, ipsilateral cerebellar signs, contralateral pyramidal signs, and the patient is having no diplopia, which is no far-sighted diplopia, or he has no divergent insufficiency. Patient has a dysphagia, harshness of voice. Now, this is a clinical presentation of the patient. Now, next is anatomical correlation. Now, I am doing an anatomical correlation of this patient. Now, I am predicting where you have a dysphagia, where you can have diplopia, this far-sighted diplopia, and where you have an ipsilateral cerebellar signs and a contralateral cortical signs. So, with this, I am predicting, okay, probably the symptoms, the clinical anatomical correlation probably will be in the pons, this thing. And the next thing I'm looking at, like, is my clinical prediction is correct? So I have to have a clear understanding about anatomy, functionality, and the clinical features, and what kind of possibility of stroke or whatever the injury can cause such problems. Now, next is I have to correlate this with the scan. So it will be a CT scan or an MRI scan. So I have to go and see the CT scan or MRI scan based on if it is a hemorrhage or an ischemia. And if I am going to, now what I predicted, is it correct? Okay, if it is like, side, spontaneous bleed, and now I'm correlating, yeah, it's the right side spontaneous bleed, or no, right side, ischemic stroke. And then I am looking at the etiology. Okay, if it is a bleed, and then it's a hypertension, all these things. So this has to be written as a report first to understand what is the care path of the patient. So this is the primary care path, and then subsequently the patient can have a different kind of clinical frameworks, the loss of consciousness initially, and then loss of consciousness was not there, and then can have a secondary care path like obstructive hydrocephalus can develop, and because of that, again the consciousness can come down, a sodium drop, and because of that, so there are many things which the clinical features interact with. So you can have a KERPA 1, KERPA 2, KERPA 3, like that, multiple KERPA one patient can have. So you have to continuously, you have to understand that and correct it. Sometimes you have to have a good understanding about the medication which is used in the neurological testing. This is very, very important. When I studied, and there was no pharmacology in that. I mean, there was no ophthalmology in the curriculum. Now all these things are added in that is very, very good, and which everything now I am realizing everything which we studied is important. Starting from anatomy, psychology, sociology, every word, everything is important. We are seeing it on ground. Once this KERPA understanding is over, and then you are collecting the history, clear history. You have to, based on the KERPA, you have to understand the history. So once this is done, what we are doing is, this is the work of the ANRs. Now I have to say, okay, as an ANRS, my work is done. Then we have a system of evaluation we have come up with. And in PRS neuroscience, we have a freedom to come up with our own framework of evaluation, and which is it solving our problem? So I strongly believe there are so many publications, which we are doing, but if the important question which we have to ask is my publication helpful to the community? That is the ultimate goal, right? So when I am publishing something, it should help to the community. If it is not helping the community, and it need to be relooked, or we have to re-look at it the way we do research. So in India, we need a lots of research on the way we are functioning itself. We need a framework to understand. So we have come up with a framework called functional body level. So currently every profession is moving towards ICF model. functionality, participation limitation. Once upon a time, only occupational therapy was talking about it. Now everybody is moving towards functionality. So we have to have a strong hold on that. So we have something called functional body level. Functional body level is about the body system, and it has 7 levels. So everything in PRS neuroscience, we have made it into 7 levels. Why we have made it into 7 levels is, if you take a work balance scale, or if you take film score, work balance scale is giving no the score out of 56, and the film is giving a score based on 7 independent levels, 0 to 7 or 8 levels. But I'm not able to correlate these two things and understand what is the future possibility of this patient. So now we have to come up with a comprehensive leveling system which will interact with each other, because the future is all about AI, artificial intelligence, system driven rehabilitation, all these things. So we will have mind space to think what best I can do rather than setting goals. So in our system, everything is 7 levels. FBL is 7 levels. Functional upper limb is 7 levels. Functional swallowing is 7 levels. So these three components are called sensory motor components. So we call it SMC, and the other one is called CVC, cognition, vision, and communication. So cognition, vision, and communication is a software. So we have to work on hardware and software. So we have 7 levels of cognition, 7 levels of communication, 7 levels of vision. This is the base level. And down is 5 level, 5 different multiple level. So this each one is the movement from pre-structural component to the functionality component. For example, movement, action, and the skill. These three things has to be worked differently. So when you're working on the movement, the patient is focusing only on the movement control, the motor control of the body. And then you're working on the action, and then you are working on the skill. So I can give you an example from the functional upper limb level. When you're working on movement, we call it P2I. So we know Brainstorm has 7 stages. So when we say Brainstorm stages, that you say Brainstorm stage 3, Brainstorm stage 2. But in our system, what we are doing is we are not leveling the patient before, we are not staging the patient before, but we give the input as an active range of motion from different aspects, because from the reflex to semi-voluntary to voluntary, the movements are moving. So in upper extremity, we are checking from different posture how the movement control is getting better. So we call it P2I, that is pattern to isolation. So initial abnormal pattern or a reflex pattern we have to facilitate, and we have to get a control over the abnormal pattern, and then moving towards the isolated movement. Ultimate goal is isolated movement. Once isolated movement is come, we are going to the next level of action, which is called isolation to pattern. I to P, we have to regenerate or recreate the pattern, which is called I to P. So once that is done, we are moving to the functional component, that is functional hand level, where the smaller aspect like buttoning, every simple aspect is put it into that, which has 7 levels. So once this is done, the right hand, left hand confusion comes, integration comes, everything is done, then it becomes full level. So we have 7 levels of full with the combination fermentation of right and left. So now how this full FBL and FSL is interacting with the film, that is our functional independence level. So functional independence level we have formulated as fill one, the FBL one, full one, and FSL one is fill one. So let me tell you briefly how we have conceptualized it, and which is very beautifully, which is working on the ground is, if you have a film assessment, and when we have a film assessment, we score it in a numerical way. But in field assessment, we are focusing more on the outcome basis system. That is, field 0 is totally dependent. Field 1 is the patient is independent on the bed. which they can perform certain activity. And field 2 is next to the bed. Field 3 is inside the bedroom. Field 4 is inside the house. Field 5 is outside the house. So this is how we graduating the patients to from one level to another level, which is also giving a comprehensible understanding. When I say field 2 patient is there, then everybody understand what need to be ready rather than no 35 out of 46. So this number is not comprehensible. We want to come up with a leveling system which is more comprehensible. This is what our idea. So now let me move to the next the challenge of working in the neuro rehab center. So in neuro rehabilitation, we as an occupational therapist, when I am working, still I'm hearing, oh, occupational therapist means acupuncture. So the word itself not it's not sounding very familiar. Or physical therapy I understand, speech therapy I understand, so psychology I understand. Why not occupational therapy? Because it is not very familiar for everybody to understand. So nowadays it is very everybody is like more than occupational therapy, OT. The word OT is very familiar. I want OT. No, that is one of the very. We have to thank the group of people who are working in pediatrics. They brought a lots of awareness among the population. How much no the OT become very popular. But at the same time, most of the students are going towards the pediatric, thinking that pediatric is a interesting area. We can see more result and more money. Obviously, everybody is working for money also. More money. But it is not true. We have actually speaking, we have the same amount of scope in neurology. We have the same amount of money, more than that in neurology, and we have more exposure, different kind of variety of strokes which I am seeing. No, we see PCA strokes, we see MCA stroke, we see ACA stroke, we see now Pontine bleeds, different thalamic bleeds. Like, how do you differentiate that? How the clinical correlations are working? All these things you can get enough when you are working in a ICU ICU setup or in an operative setup. Now, one more thing, one more area which we get familiar with is the movement disorder. The second thing, apart from this, the I understand if you are in neurology, if you are good at stroke, your life is settled because that many stroke patients are coming. And if you are good at head injury, your life is settled because the number of head injuries is going, no, it's increasing every year. It is increasing significantly. And then Alzheimer's. That is the third condition. So if you know these three conditions, stroke, head injury, Alzheimer's, your life is settled forever as an occupational therapist. That is the fact in India. Now, spinal cord injury, I didn't tell. I didn't tell about movement disorders. I didn't tell about other degenerative disorder. So many things are there. So the scope is infinite, and it is new kind of new. Yes, one side it is their curse, but the possibility of expansion for occupational therapy is huge here. Now, entering into acute care is very important because occupational therapy means when my uncle, he's an ophthalmologist, when he put me into the college, he told you people work in tertiary rehab center somewhere in no outskirt. When one center will be there, they will be working in that. This is what known for. But what I'm seeing is our therapists are going into the operation theater and evaluating it. Let me tell you those things also. Now, what is the huge possibility of occupational therapists moving from the tertiary rehabilitation to the acute rehabilitation? Because already the physiotherapists become the primary health practitioners. We also have a huge possibility of moving towards acute care. Now, I just correlate with the pediatric possibility which we have, that there are many people working in acute care. It starts from neonatal ICU. When I was working, sir, am I taking more time? Sir, let me know, sir, if I'm taking more time. You have any time limits?
No, Ganapati, you're going on fantastic, because whatever we wanted to ask you, you have been, coming up with those points exactly.
Thank you.
No,
Thank you
just
so
just
much.
to go ahead, because you mentioned something about the remunerability of being into the neuro rehabilitation field, because that becomes a major topic for all
Yes,
the young OTs to take a different path.
exactly.
This is also opening up. Yes, being someone who is also practicing neuro rehab, I know how much remuneration it brings. Even though I'm seeing less clients, it brings the equal
Yeah,
amount of remuneration for me
correct,
than what
correct.
I'm seeing in multiple numbers in pediatrics. So,
Yes, yes.
for the people to understand, as you said, the acute care rehab, Gopal is doing fantastic in acute care rehab. He's addressing medical intensive care OT, and you're in there. So, if someone like in the audience or in the new generation who is coming up to get trained, because it's not going to be easy gaining the confidence in working in the acute rehab of neuro rehab. It's not that easy, you know.
Yeah.
So, what would you suggest where they can go for training and help to boost their confidence and hands-on skill?
So there are two things, like whenever I'm talking about the rehabilitation, there are two things, like I told the care par ray model. One, the rehabilitation. Many therapists are good at rehabilitation and they know what modality to use, all these things and all. And it has to be strengthened by the ray, the care par, that is the clinical model. So you have to have a good clinical correlation. That itself give a good confidence for you to become a successful neurorehabilitation profession. That means your language has to change. And in occupational therapy, if don't mistake me, we should not use no very common words. We have to use more scientific words. And in the sense, OT is a very dynamic profession when I compare to physiotherapy, because physiotherapy is like mathematics, like you do this thing, you will get this result. But OT is using very different way approaches. So it has multiple way to look at this patient, dynamic, holistic, and a spiritual. So many things are involved in this thing. It is not physical,
Exactly.
physical.
Exactly.
So when we are talking to people, we need first a structure and then become dynamic. That is very, very important. So we have to start from the structural deficit and then functional deficit and then dynamic deficit. Because dynamic, if we start from the dynamic, it's very difficult. That is why it is very, even for me, it's very difficult to understand what occupational therapy is talking about. That itself, no, we may have to write a book to decode occupational therapy textbooks. In Indian context, we have to decode it and write it. So if I have to use a structural framework and a dynamic framework, because as a young therapist, I don't have any clue what they are going through psychologically, what they are going through culturally, contextually. So when you say context, what is environment, what they are talking about, all these things are quite challenging because you need lots of wisdom to understand that. But a structure is
True.
very easy to
True.
understand. This is 1 + 1 is 2, isn't it? So this is first thing I feel. Second thing, as young therapist, don't ignore anything which you are studying now, because we have done that. Because we thought, okay, are we going to anything which you learn is going to be useful. The medications, the physiology, there's anatomy, everything is useful. So, for example, I'll tell you, when you are going into an ICU, what make you more confident is you should be able to read the case history. You should be able to read the patient symptoms. You should be able to read the monitor. These three things are very, very important. If you don't know how to read the monitor or the ventilator, you will not be so confident because every time the monitor make a beep. So you should know what are the vital parameters when you are going inside the patient, and you should know what are the medication they are on. Say for example, as an occupational therapy, we are going inside. If the patient is on mannitol, which is actually sedative, and if they are electively sedated for the intubation, we cannot go and say that I am here for giving coma stimulation. So when do you start coma stimulation? That itself an important thing. So for that, you should know what are the stroke condition, what is the head injury, what are the surgery they are doing, why they are doing decompressive craniectomy, why they are electively seducing the patient when you are intubating. All these things give a huge amount of confidence when you are entering into an acute care setup. Of course, our role of as an occupational therapist, not we don't have a huge role in ICU compared to a physiotherapist, but you can get into that because you have to start family-based rehabilitation from there. And when they are, because most of the time they will not be, even their health condition is not improved, they will be moved from the ICU, put in the ward with the tracheostomy, with the NG tube, with the catheter, with the loss of consciousness. They will be moved to the ward once they are medically stable. Then you have to start, obviously, you have to start that. So, this medical management of the patient and the surgical management, what is done, is very, very important for you to interact with the therapist with the doctors. If you have a good medical lingo, you can get into their mind. That means like, see, I don't take me otherwise. Most of the time, the neurosurgeon and neurologists, they all think we are gods. No, we are gods. Okay. At least we have to go and say we are also one chota god. No, we are also one small god. So we will be in their group. We will not be. We have to get into the team because we are going as an outsider in an ICU. And even it is uncomfortable for me after 20 years getting into an ICU means imagine for a fresher how uncomfortable or how frustrating for them. So we have to use a very strong medical lingo there to get into their mind as an occupational therapy. Oh, this person makes some sense means they will ask, who are you? Then occupational therapist. That makes sense. That is the first thing. Second thing is uh, getting along with the other professional is also very, very important because if you work on the funda of occupational therapy very clear, because I had this challenge. So most of the time they ask physiotherapy also doing the same thing, you're also doing the same thing. These are all the same questions.
Same
So
questions.
yeah, same questions. We everywhere we are facing it. Now I have to tell them what is occupational therapy. From the foundation itself, I have to tell. So simply I say, you are like you are starting from the structural core to the function, from inside out. I am, as an occupational therapist, I am moving from functional core to the structure. This is the simple way. That is, it is like the micro, what the macrocosmos has is the micro cell is also having the same effect. That means if you change the microcosmos, you can influence the macrocosmos. The same way, when you're working on the macro, you can influence the micro. This is the way you interact with it. That means you're moving outward, you're moving inward. This is the direction. We may be opposite, but we are working in the same direction. So it is not about occupational therapy, upper limb, physiotherapy, lower limb, and speech therapy, mouth, and no psychology, mind. But what I have understood is we as an occupational therapy, when I look at a curriculum which fit very well to understand each profession. You know administration, you know clinical, you know the physio, you know psychology, you know speech, swallowing, so many things. Why do you have to know? Because ultimately you have to deliver the functional independence. So whenever you put a goal, you have to keep the functional independence in the mouth, in the ICU, sorry, in the mind when you are in the ICU, when the patient is in ICU. So you have to have a good probable prediction and have a in 2 years where the patient will be, in 1 year where the patient will be, in 6 months where the patient will be. This kind of judgment you should be able to take so that it will be good for the young people and them. Yes.
Ganapati, thank you so much. Sorry for cutting you short here because we have a couple of
Yes, sir.
questions
Yes,
and
sir. No problem.
hands raised. So when you said, having the basic understanding or sharpening our basic skills, when I joined post graduation in Mumbai TNMC hospital, the first thing was when I was posted in the neuro rehab or neurosurgery OPD, one of my senior lifted up the CT scan and then showed me like, read the CT scan and tell me what it is. Very, very plain of me, I said, like, I haven't even seen an X-ray, so how will I read a CT scan? Because obviously, that time we were not taught about X-ray. We were not taught to read the radiological images or radiological differences. Then, I told her literally, it was like a fight between me and her, but of course a healthy fight. So I told her, like, I don't know. That's why I'm here doing PG with you. So you're a senior, you teach me that. And she did, and lots of other seniors as well who taught me on reading the radiological findings. Of course, this becomes a important factor of sharpening our basic skills, keep learning the new advances coming into the field. OT wise, therapy wise, we will be, doing our own stuff. We will be able to do better with our creativity. But knowing what causes that functional impairment or what causes that lesion is very important. So going back to the basic of understanding neurophysiology is very important here. Coming to the question, I think you have answered almost the first one. Someone asked, what is SMC? And then I'll go to Purva's question, because Purva's question is very important here.
Yes, sir. So I just complete the CT scan like this one. So it is not like we have to know all the radiological findings. You have to know the base radiological finding of looking at a CT scan, looking at an MRI, and because when a neurologist look at the CT scan, he's looking at for a different reason. When an occupational therapist or a therapist looking at the CT scan, you're looking for a different reason. Because a neurosurgeon is going to do a surgery. We are not going to do a surgery. And he is going to give a primary diagnosis for you. But when the patient coming to us, we have all the diagnosis, everything is done. We are using the CT scan or MRI to understand what is the probable functional deficit the patient can have based on the anatomical location. So this is also an important skill everybody should learn. And we should not hesitate to look at the CT at least. Just see that every day. Over the time, you can comprehend it better. And the question which you asked, sir, what is SMC? SMC, correct?
Yes.
Yeah. So SMC is sensory motor control, and the C, which is hardware, which is what system which we have used is our human body is working as a computer model based on that, the input, processing, and output feedback. So this is what the process which we have used. So when we analyze sensory motor control, we are analyzing only the output. So the software is CBC, which is communication, vision, and cognition. That is what is happening inside your brain for you to give that result. So then again, the sensory feedback has to go. So the sensory motor control is the output which how we measure as functional body level, functional upper limb level, functional swallowing.
Good.
Is it clear, sir?
Yes, Ganapati. So I'll take Purva's question first. Because you answered, there is Muthu Krishnan's question. How do we work differently from physiotherapists among neurological conditions in India, which we almost touched upon and we clarified that aspect. From my end, I just wanted to say that, nowadays the whole dynamic of understanding what OT does and what's their scope in India is also improving amongst the neurologists and the medical professionals. They know why they need an OT. They know why they need a PT, and then they start referring. That we can identify or we can understand by the gap between the diagnosis to the rehab appointment with an occupational therapist is reducing. Usually we used to have people coming at 3 years, 4 years, and 2 years. Now we get people in 10 days, and even the day of their stroke, they call up and, okay, this is related to it. We want to have you as an OT. So this is what is going on, Dr. Muthu. This is on that aspect. How do we encourage students here? From my aspect, since I'm practicing it also, when they see this is giving me clear advantage or a field where there are lots of things to explore because there are lots of pediatric centers and therapists who are working in the pediatrics, but there are less people who are working privately for the neuro rehab, which isn't much need for now. When obviously everything boils down to your remuneration and your expertise, you become the single person or you become the one person in that particular area to practice and create your name for it. And then all the neurologists, like 10 neurologists, will refer to one therapist or two therapists in that area. But as of now, there are 10 occupational therapists sitting in one location, and there is one developmental pediatrician referring to all 10 people. So now you know why the students should consider this, and we can convince them to get into the neuro rehab field, because this is again coming up good. And as an occupational therapist, we touch upon everything. Live example is sitting right in front of us, Dr. Ganapati. He did work in pediatrics. He did masters in pediatrics, but he's excelling in neuro rehab care. And how many of us have done neuro rehab and ortho rehab, but still going on working in pediatrics? I don't say doing specialty is restricting us. It is improving our skill and knowledge, but at the same time, it doesn't restrict us from working in one particular area alone. So that I want to put it for all the people. I saw Karthik's hand going up. Karthik, you want to say something? Then I'll ask Senthil sir to open.
No, I just want to it's all beautiful information. The flow in which he was talking about shows his expertise. I just want to commend him on that, and then just to kind of like redirect you to look at the chat. That's why I texted you. That's fine. So we are good. There's a couple of more questions as well. Like, the Muthukrishna asked, why do we need to read radiography? Are we take accountable if there is any mistake on the radiology finding? So again, basically, like, he's asking, why do we need to learn to read all these things, which you touched upon? But if you want to add any more, please go ahead. And I see a couple of hands as well going on. So
I just want to link this couple of discussion earlier which has happened. Why we have a huge potential to move towards the functionality is now earlier model of therapy where more of motor control based theories. Now we are moving more towards the ecology and system based theories. That is task oriented approach, all those things. And and the physiotherapist also moving in the same direction, functionality. And so for a physiotherapist, task oriented means picking up a glass, bending and picking up it, this kind of task, kicking the ball. This is what I heard. But on an occupational therapist, what task oriented means, what is a task for me is brushing, not just brushing, getting up, going, picking up, looking at the brush, recognizing the brush. So I have to have a clear understanding about vision. I have to have a clear understanding about communication. I have to have a clear understanding about cognition, how he is processing, if he has an agnosia. I can give you hundreds of case examples that how, what different kind of. So we have come up with a complete vision rehab logic for us. There are the vision not from the globe. It is starting from globe to all the way to the primary visual cortex. Again, it is traveling all the way front, all the way down, and then it is going. That means 99% of the time, if the patient is having a brain injury, one or the other visual problem will be there. It has to be picked up by an occupational therapist. It will not be picked up by an ophthalmologist. The problem is, it is not the problem in the vision. Now, what is dyslexia? It is not a learning problem. It is a reading problem. It is a visual problem. He is not able to see the word as a together. So who knows this better? So now I have to understand, if a patient has the PCA stroke, which is on the left side, which is on the inferior temporal lobe. If the stroke is there, I can predict what is the possibility of functional outcome. So this patient can have prosopagnosia. This patient can have alexia without agraphia, with agraphia sometime. So now you know agraphia, but you don't know PCA. So if you know PCA and agraphia and dyslexia, that's going to be very beautiful to say the story together. Now, the second thing is, when you say task-oriented approach, all these things, it's all about functionality, right? Now, I should know Everybody is moving towards that. But as an occupational therapist, I have a higher chance of understanding the function better because our curriculum support that. We have to make the curriculum a little more structured to understand and then make it to dynamic. That is what my perspective. So
Thank you,
radiology, I
Ganapati.
answered.
Yes, thank you,
Radiology, I
Ganapati.
answered. Yes.
Yes, you did fantastic. Due to time constraint, I'm going to wind up with the last three questions. You did touch upon why it is important to go for reading radiological findings. And I also find that connected to the medical lingo question which Purva is asking, unless until we know the radiological findings or clinical features of pathological findings of the particular disorder, we cannot knowledgeably discuss or order, say things in front of a medical practitioner or even for a knowledgeable caregiver. When you say things or when you just bluff things, they will pick up immediately and then they'll throw you out. Okay, you are not good enough for me. And to prove our worth and prove our quality in front of them, we should be knowing the medical lingo in a better way. At the same time, knowledgeable discussions can happen over this when we know the stuff clearly. The neurologist will easily figure out. That is when he will make you sit in front of you and discuss with you. Otherwise, he'll be like, okay, go do this, go do that. He will treat you as a third person only. To get that proper respect from them, we should have that understanding, or we should have that pathological knowledge about that particular condition. Moving on, there is something which is very important for me. I see both people's hand, Dr. Muthu and Dr. Sendil sir. I'll go with Sendil sir first. Sendil sir, you have put your question in the chat section also, but I want you to ask it in person.
Okay, Murli, thank you. I want to really appreciate IOTT team and especially for Dr. Ganapathi's excellent sharing of his beginning of his history. So I was very wonderfully appreciated, and same history also myself. So I'm really.
There are many people like us, sir. We have to
Yes, sir.
appreciate
Yes,
them.
yes,
We have
yes.
to encourage them to bring
I'm
to the higher levels.
good job. I just wanted to ask some entrepreneur related questions to you. Just I already done a chat box to you, just to share your experience and how you will give us some guidance. Those who are young entrepreneurship in neuro rehab field, like pediatric or adult neuro. What kind of advancement or technological tools or equipments exclusively for OT in practice, current practice in India, such as I know just terminologically like robotics and some VR, some other digital tools. So for as you are expertise in particular field in a decade and above, so what kind of equipments is presently in India, and what the some tentative cost of practice? It might be useful for those who are entrepreneurship for in youngsters as well as those who are practicing that particular field.
Okay. So now in one of the biggest challenge in India is the financial investment for technology. For example, if I have in our company, what we strongly believe is make in India. So, and for India, make in India. And I know it is very difficult, the FDA, all these kind of challenges are there, but it is possible. In affordable rehab solution is the only way forward in India because everybody cannot afford a robo or no unweighing system, which is imported, and we cannot put many patients in that for the get the benefit of it. Of course, we have technology in our own way. We have made technologies, for example, the unweighing system or the exoskeletal system or the biofeedback system. We have also now we are working on something called motion capture system, that using a motion capture camera, using our own way of logics and other things, we have put it in the system and understand how the patient is moving. Based on that, can it give a output? So why we want to do, let me tell you, the brain is still the old fashioned wired model. It is no, it when we are using a robotics, is it improving? I have no personal experience. I have no personal experience. I don't have any hesitation. I'm not expert in robotics. I'm an expert occupational therapist. I believe in hands. I believe in touching the bottle. I believe in drinking the water. I believe in experiencing what is happening. This is very, very important. So how much the exoskeletal system work, I have no idea. That somebody who is using has to tell. It may be helpful. I don't know, but somebody has to tell me
Ganapati,
an
can I
insight on that. Yeah.
Sorry.
Yes.
So since you said the experience part, I'm also personally someone who relies on my own way of doing it, and traditional way of doing it, and which has given me great benefits all the more. But at the same time, I have seen quite a few equipments, sir. Senthil sir, this is directly in what you have asked. There is this company called Galanto. There is this company called Raimo. They have this products only on shoulder. They came to my clinic with the demo piece. I was in awe with the equipment what they have brought in for shoulder and hand. Fantastic equipment, AI based. It reads how much power we are giving. We can set on how much it can go. Of course, it needs final fine tuning and tweaking, because as a therapist, we are not satisfied with what the machine is giving. We are always in the adaptive response mode, where every time there is a change, we are providing with the client. So I've given them inputs, but they said they will get back to it. But they have limitations. They have limitations in the form of what, as a therapist, what we want to proceed and move forward. No, it has limited scope for changing it mid of the movement, mid of the therapy plan. So that's where I am a little down with the plans. But they have a fantastic balance board games and VR games which will improve perceptual skills and postural awareness. There is something called Mubi L. There is something called what is that? What is that? With the Galanto, they have a glove which attached to the hand in different components. They are also doing great. The glove, I think it is coming with the Galanto invention. It is coming up to 3 lakhs, I suppose. I'm not clearly sure, but it is somewhere around 3 lakhs, customizable. And with Rhino, the shoulder and hand component machine, which comes to 6 lakhs. And then there is only hand component table. What they have this reaction time lights, which is very fantastic, which can improve shoulder movements as well as perceptual skills in the adult category, which I was in love with, which was costing only 60,000 rupees with the tab and with the system. Balance board, which is AI connected again on the pressure plate concept, which was coming somewhere around 70 to 80,000 rupees. So there are equipments which we can buy, because 70, 80,000 as a neuro rehab professional, I would definitely buy. But will I touch upon something which is 6 lakh and 7 lakh? I will not, which I told them I may not touch that product as of now, because as a small practitioner, I won't need it. But a corporate hospital or a big hospital, they can buy it. So there are quite a few innovative things there, and it is definitely available. I would send you some of the contacts for you, sir. Finally, due to the time
Thank you,
constraint, I'm
Murali.
going
You
to take
can
up.
send me the contact because one of our professional well-wisher is joined, my friend. I told him to join. He's IT personnel. He's more interested to know about this, and he has some plan to involve in our rehab field. So he's
Fantastic.
an IT specialist. He's joined in our meeting. So that's why I asked this question as well.
Fantastic, sir.
So thank you for
Fantastic.
your information. Might be have a collaborate with some IT personals in future as well.
Great, great, sir. Great going, great going. Uh, f- uh, just before going in, Dr. Muthu, you want to talk? Please unmute yourself and say, Muthu Krishnan.
Um, yeah, good evening, sir. Actually, it was a very good session from Dr. Ganapati. Thank you so much for so many information that you shared in a very limited time period. Uh, because of the time concern, my questions, and now it is just around my question only, because you said that we can practice in all, as occupational therapists, we can practice in all areas. So in the same way, the physiotherapist or the speech therapist or any other rehab professions, they will also think that they can practice in all area and they will come and practice in our area. So we need to be very clear that what is our role in neuro rehabilitation and how we differ from them and where they can't touch us, where they need us exactly. Because one thing, entirely we differ from them in a cognitive rehabilitation because the physios can't enter, even the speech pathologist or whomever, they can't enter in the cognitive rehabilitation. And how much we are making awareness to our students to get into the cognitive rehabilitation and what all the standardized tools we use to assess their cognition and how we are managing in the area of stroke or any other neurological conditions. That is one thing I just want to ask. Yeah, the other one is exactly about the radiological reading. So, however, they have the profession because we are not doing any scan or we are not doing anything. So, the person who's responsible to refer to a radiologist or the person who's making the scan, they are responsible to take their diagnosis. They are responsible to find, to inform us what is their findings from the radiography. So once, if we have a very good neurophysiological knowledge, then we can talk to the doctors or we can just talk to anyone else. We don't need to have radiological reading knowledge for that. So once the radiographer gives what is the lesion in their brain. So if we know the neurophysiology, so we're going to speak to them. What were the things? What is going to cause for this physiological deficit? What will happen? So that's how we are going to administrate. And also the last one about because if you want to establish neuro rehab in India, um, for example, even if I want to pursue my career in neuro rehab in India, what is the student outcome in a year in India, OT students outcome, and how much neuro rehab opportunities we have? Because, for example, if a 10 person wants to choose a neuro rehab in Chennai, do we have 10 specialist neuro rehab center in Chennai? So, and how we are going to make awareness of the neuro rehab professions or the doctors who's treating the neuro rehabilitation in Chennai. Yeah, these are all my questions.
Sir, just for the time consent, the last part where you said about the students coming out in the neuro rehab field, as private practices, as hospitals, we have no control over the colleges providing that stuff. So there are professors who are educating them, but I am very sure, and you also know it, any part of the country, the practical exposure is very limited when it comes to private colleges providing neuro rehab experience for the children. Government colleges might have better caseload, but at the same time, some of the government colleges might not have staffs to educate them, even though they have the cases, which is a totally different ball game when it comes to this. Other questions regarding the need for the radiographic knowledge, I'll leave it to Ganapati.
Sir, one point which I want to connect to Senthil Vadivel sir's how to expand the business plan and Muthukrishnan sir's radiological requirement for occupational therapy. I agree, as an basic occupational therapist, you can talk to the the neurologist, understand what is the functionality. But when you want to elevate as a clinical, like it's after a HOD of occupational therapy, what is my next thing? That is ANRS, Advanced Neuro Rehab Specialist. When I have to understand what is the overall understanding, then if you want to elevate yourself clinically, it is good to have that knowledge also. That is, it is not mandatory, but it will add a lots of comprehensive value for the functional deficit, I feel. Because most of the time we will not be able to directly communicate with the doctors and we will not get that much time to understand it. So all these challenges are there actually, and the doctors has to teach. All these challenges are there. But as a OT, it will help us to coordinate the different. For example, if you're working with a physiotherapist, speech therapist, all of them, to understand their roles and their functionality will give a larger understanding about how to handle the patients. So we learn about like how to do MBS, modified barium swallowing test, which will understand like feed the patient during the session. So this is going to give our comprehensive level better. That is the on ground use of radiological. It is not mandatory. It is not really mandatory because the radiological report will clearly tell what it is. But even the radiological report can miss something, so which you can pick up in the images, and you can obviously we can discuss with the neurologist or neurosurgeon if we have enough time. And but
Uh,
there is no harm looking at the scan and learn it. It is
uh,
not mandatory. It is not mandatory.
Ganapati, I want to say something on this personal experience what I had with some of the clients. So these people are some of the cream of the creams in Tamil Nadu people, where they need rehab people as an occupational therapist to go and see them. You have a team of exceptionally top class neurologists, neurosurgeons, and physiotherapists sitting there and talking. So when we meet them and talk, if we go without knowing the basic information, and then to back our therapeutic plan with the clinical statement, we are easily thrown out. That's more some of our therapists know already because they have been gone there and then they have been sent back. Also, we also know somewhere when you give an explanation, when you give a therapeutic plan to the client, they will see through you and then like, okay, you are not convincing enough for me. And as I said,
Yeah,
for the people to
yeah,
refer to you, which is important, it. It is not mandatory. Of course, the working conditions are different when it comes to the other countries and India, because where we are in a hospital, everything goes through a step-by-step flow. You come through for that plan, and then you are given, okay, this is what you're going to do. But in India, you go to a client where there is nobody else involved. They go 3 months once to a neurologist to review also sometimes. There is no physiotherapist definitely involved at all at some point of crisis. I have I have a radiologist who is coming to me now in my clinic. The main focus for me is to make him go back to his radiologist job, where he is going to do an ultrasonography, he's going to do an MRI, where his major thing is sitting in that ultrasonography machine, where his left hand is affected. He needs to tweak that machine, and then joystick manipulation to come to the points and then click on that point to take the picture of that particular image, which is directly we are involved. I'm also addressing the point where how do we differentiate, because as an OT, my focus is majorly on sending them back to the job what they were doing and making sure they don't get thrown out of the job, because the radiologist immediately said, I need to be at my best to do my scan, so that the big hospital I'm working will rely on my findings. So this is one. And on the other hand, there is somebody who is completely for the 6 months in coma, and then there is no hand movement, clear subluxation is there in the right shoulder. When we start going, suddenly we are trying to get the movement. There is tapping, there is passive movement, there is joint compression getting. But the final goal is to move the hand, get initiation of the muscle control, muscle contraction. Now the focus is to hold on to something and just bring it close to the mouth. It took me 6 months to work on that guy to get that movement. Finally, what the goal is, he has to take his water bottle and drink with his right hand. He can eat with his left hand. Of course, eating on the right hand may not be possible because it's already 2 years post the stroke and 2 years post coma of 6 months post. So it's 2.5 years almost. So some places where we need to be clear on making their independence, making their functional task easier, and attaining that independence in that productive occupational related way. That's all. Returning to the job is the main. Returning to the productive part of their life is important. Either it can be ADL skill or it can be work related. Okay, Karthik, please go ahead.
Yeah. All right. So again, it's an excellent discussion. It's very, very hard to stop and all, but at the same time, we need to be mindful of the time. But I just wanted to say two things. One, in response to Purva's question, how can we develop good medical lingo? I would say you need to master medical terminology first. Okay, so there are like a lot of resources available. Maybe on behalf of IOTT, we will see whether we can do a session on medical terminology. But like mastering a medical terminology will kind of really equip you to develop that skill much better. That's my 2 cents. And also, like to Ganapathi's point about like explaining what OT is to a stakeholder. Of course, with more and more OTs, with more and more clinics now are in place, people are know what. I mean, at least they are hearing OT, OT, OT. But just so that it's very very important skill for every single occupational therapy emerging OT student as well as OTs to explain OT to a stakeholder in an understandable manner. And for that, IOTTT has developed a very simple layman definitions in Hindi, English, and Tamil, which is available on our website. And we want to we want to find more experts who are bilingual in their own language, and we want to expand, translate the definitions to multiple languages as well. So if you're interested, please reach out to us and help us do that. So that there are some resources that are available on IOTT's end as well on that. So Dr. Muralikrishnan, just for the time's sake, if you want to ask Dr. Ganapathy some final wrapping up thoughts, and then we can conclude the session. Thank you.
Ganapathy, just of course, we will wrap up with your final 2 cents. Please provide a way for all the occupational therapists in India to lead why we should be pursuing neuro rehab as some of our primary primary job focus as go into neuro rehab. Very briefly, please.
So as I told that, when you're working in multidisciplinary team, we're all comfortable working as an occupational therapy in a center. Only occupational therapy is provided. We have to expand our knowledge and the confidence level and the clinical skill set to understand the clinical and the rehab, include all the 4 professionals, maybe like 5, 6, include social workers, so many things. You have to be very comfortable working with them. Then it is very easy to work in a multidisciplinary team. And also, as Sendil sir told, if you want to start a center, you are the right person to start. Because if you have a clear understanding what a different professional do, you have a high chances of learning it. You're not looking at only structure, you're looking at functionality, psychological, so many other factors. So as an occupational therapist, you have a high chances of understanding how this flow in neuro rehabilitation. That is first thing. Second thing, neurological deficit has multiple different aspects of disability, not just a physical disability. And it has a cognitive disability, psychological disability, so many other disabilities are there. So you have a scope, long-term scope is there. And the third is financial, which is a myth, which pediatric has more money. The fact is that the more money and the more charges are happening in neuro rehabilitation. Don't look at the service-oriented hospital. Of course, I worked for 7 years, which gave me the compound effect when I moved to a corporate center, corporate hospital. So do not compare this and say that there is no money. Money is there, obviously. But one question which I have to ask is, am I delivering for that money? It can be 1,000 rupees, 2,000 rupees, 3,000 rupees. Sometimes you ask 5,000 rupees. But are you, because some of the psychological evaluations are 5,000 rupees, 10,000 rupees. But are you delivering back? That is value for money. Are you generating the value? For that value, we need a deeper understanding. We have to be strong in our core clinical knowledge. Thank you.
Fantastic, fantastic, Ganapathy. Rightly put. There is a hell a lot of world to conquer for us in this era. So I would say we have so much of scope outside as an occupational therapist. Now we are all pushing boundaries. People are consciously coming and asking, okay, OT is this, and then we want OT for this particular client, and we have gone into that era of breaking that awareness stigma, and then we are going into creating awareness as well. I know every time there will be some of the people coming and saying, okay, we have not heard about occupational therapy. Good for us. Good for us, because if they have not heard about it, they would have not come to us. So the need for it is also improving. And I know we are looking at it in a different aspect also, which is morally seeing, yeah, it is it's the wrong way of saying, but the future holds lots of prospect for us. And thank you, Ganapati, for bringing in such a wonderful experience of yours and enlightening us. It is good to have you here. And I thank you for the time and your knowledge you spent with us.
Thank you very
And
much.
thank
Thank you.
all the participants
Thank you.
and
Thank you, Karthik.
exceptional questions
Thank
from us.
you. Yeah, thank you, Dr. Ganapati, for your time and for your willingness to do this for us today.
Thank you.
Hopefully, like we can invite you for as a webinar speaker on a neurological based
Definitely.
topic, because like we already
Yes.
had some comments there. Please work with us, continue to work with us. And I want to thank each and every one of you who joined today. Hope this was helpful. Look for more offerings similar to this on behalf of IOTTT. Again, I want to extend one more call to invite all of you to consider joining IOTTT. The recording will be made available on our YouTube channel soon. Please continue to join us for our future events and continue to support us wherever you are. Enjoy the rest of your day, and thank you so much. Yeah, go ahead.
Karthik, just to put a word, we did
Sure.
this topic, and then I saw Purva here. Purva is
Mhm.
someone who's starting her neuro rehab setup very soon, and then and we I'm pretty sure we have given her some information which would benefit her in her practice. So
Excellent.
fantastic
Congratulations,
discussion.
Purva. All the best.
All the best. Thank you.
Thank you, sir. Indeed, it was a very good session. I enjoyed listening to all of you.
All right.
Thank
Take
you,
care.
everyone.
Bye,
Thank you.
everyone. I'm going to
Thank
end the
you.
meeting for everyone. Thank you. Thank you,
Happy
Ganapati.
weekend.
Thank you so much.
Bye.
Yeah,
Happy
you too.